also BD and Medtronic as well. And then they go on to do the hard work, which is actually coming up with a new, creative, innovative solution. And the beauty, again, as I said here before, is that they are now have the access to a wide range of technologies available in our department, but also across the university and across the world. We're totally agnostic as to that. Their job is to solve that clinical problem, whatever it takes, wherever the solution can come from. And they do a fantastic job as well, I think, in this stage. And they also, in the course of doing this, they develop the IP, they report the IP, and they get a lot of input from regulatory, reimbursement, manufacturing, and technical perspectives. And the beauty of it is the feedback comes in early enough in the process to actually impact the design. For example, we had one of our projects was a early detection for preterm labor. As you know, a regular delivery cost about $5,000, preterm delivery, $50,000. If you can detect that early enough to intervene, then that's a big savings to the healthcare system. It's worth a lot. So the students had developed a really cool technology. It's a device that sits on the cervix, records microcontractions from the uterus and the bottom of the uterus and the cervix that can detect the early signs, early warning of preterm labor. So, but the device the designer required the device to sit on the cervix of a pregnant woman for a week at a time collecting data. So with our input from regulatory officials, we're able to get a clear picture that the hurdle for that type of device that's going to stay in place for a long period of time is huge. And if you could reduce that down to an episodic thing where it's only a couple of hours in the clinic, the doctor places it and then takes it off, the ability of that thing to efficiently get to the marketplace and get through regulatory clearance will be greatly enhanced. So the team went back to the drawing board and developed a technology, an approach that could collect the same level of accuracy, slightly less accurate actually, but much more likely to get to the marketplace quickly. And those are the kind of trade-offs that often don't happen in academia. I was at the AIMBI meeting, the American Institute of Medical and Biological Engineering meeting in Washington a couple of days ago, and there was a fantastic talk by this gentleman who makes orthopedic robotic legs. These things cost about $30,000 a piece. The guy he was a professor at MIT, and he had two robotic legs. And he could run, he could hop, he could jump. And I asked him, I said, Professor, but there are millions and millions of people with disabilities that need not $30,000 worth of legs, they need like $300 worth of legs. Can you make something like the Jaipur knee or the Jaipur foot that's low cost but durable? So the problem with that device is that it fails, it breaks down very often, very soon, and can you do something like that? He says, no, I'm not interested in reducing the performance of my device at all. If you want to do it for developing countries, then figure out a way for them to make this quality product there. I said, that's wonderful for 20 years from now. I mean, this device is barely able to be made at MIT, the best university engineering school. Am I running out of time with it? Yes, okay, I'll speed it up. So the students are required next to implement their design, build prototypes, test it. They take it as far as preclinical testing, cadavers, animal models, whatever is appropriate at that stage. And they also build a business plan, as I said. They do a really good job at building the business plan. So here's some examples of technologies that they've spun out of our center in the last 3 years. I don't have time to go into each one of them. There's ServoCheck, which is the early preterm labor detection. The one at the bottom left, Seguro Surgical, is a device that went from a white piece of paper to first in man in 3 years. It's a device to pack the bowels efficiently, quickly, and it's doing very well in the market. GentleMed is a device to deliver medication to the eye. It delivers 90% of the medication as opposed to half of it running down your cheek if you've ever had eye drops. And it delivers it horizontally, so you don't have to bend your head over. And it shoots the medicine in your eye with such velocity that even if you blink, nothing, they'll all get in your eye before you have a chance to blink. But with such little force that you barely feel it. It's really cool. Here are 3 from this year's class that just graduated. They're all 3 very solid companies. All 3 of them have been heavily vetted before they even were launched. the students came up with wonderful innovation ideas. I say students, but it's actually students working with faculty. And all three of them have received follow-on funding from both from our Technology Acceleration Fund and from state funds. And they're seeking angel funding as well. So as I said, the students have done very well on the business side and at various competitions around the nation. Recently we launched a version of this for the faculty. It's called the Coulter Translational Partnership. It's funded by a $5 million grant we got from the Coulter Foundation. I also head this organization. And basically we're going to be funding 6 or 7 projects that are run by faculty and not by students every year through this. So you can imagine now we have 12 undergraduate teams that I didn't talk about. We have 4 master's teams, and now we'll have 6 or 7 faculty teams. So we have a large pipeline of medical innovation that's focused on translation and commercialization in our program. And the Coulter program has been very successful at 10 other schools. They've already had a 5-year track record, including Stanford, and they've had a 7x return on the investment in terms of VC funding and follow-on research dollars for the money they put into that, with over 28 companies that are venture supported coming out of the program. So this is our oversight committee, including your own Dr. Jain is on this committee, and we're very honored to have him there. And as you can see, there's a good mix of clinicians. These are all clinicians who've actually had companies spun out from Hopkins, leadership on the academic side, several people from industry and investors who are going to be making the funding decisions. So even this is revolutionary for academia. So we get the money, and then now the decisions on who to fund is not going to be based on the typical politics that goes on in academia. The decision will be made by this outside panel. I also have several slides on our Global Health Innovation Program. Can I talk about that? This is probably the most exciting program that we have here at Hopkins. And it's all about taking the insights of first world innovation and the insights that you get from developing in technologies in very low resource environments and somehow bringing them together into one program. So all of our student teams do a combination of both first world medtech innovation and global health innovation. Why did we do this? We feel like if we're training the next generation of medtech innovation leaders, we would be remiss if we did not also train them how to develop technologies that are going to be appropriate for global markets. That's where the growth is in our industry. We also feel like if America is going to maintain its leadership as the medtech leader, then our engineers need to know how to make high-performance, low-cost medical solutions, like the One-Touch Ultra Mini. And the students really sink their teeth into it, heart and soul. So it's a wonderful thing. And plus, when they go to look for jobs, it helps a lot to know that they know how to develop stuff for developed markets and for global health, for global markets. But one thing we're trying to do differently from other global health type programs is that we're trying to integrate the two into their thinking. That they have a unified design thinking that includes the concept of frugal engineering, of high performance and low cost. So the way we go about this is the students do this clinical immersion 2 months at Hopkins. What we've done, instead of 3 months at Hopkins, we made it 2 months at Hopkins and 1 month at some of the most resource-constrained hospitals in the world. So when they go to India, they don't go to Mumbai. They go to Mahatma Gandhi Medical College or other rural areas. So they get a real feel for healthcare in its pristine state, where people are kind of like MacGyver. They have to say, I have to solve this problem. I need to use the resources I have at hand to solve it. I don't have a wealth of stuff at my disposal. And it's been a wonderful experience for the students. They do the same thing, and then over the course of the year, they develop in parallel to the regular innovation, they do one of these global health innovation programs. And it's an integrated approach. Give an example. We created recently what we call a Day of Birth Alliance with 3 partners. Our center, JPIGO, which is present in over 50 countries global health, including India and Afghanistan and sub-Saharan Africa. And then Laerdal Global Health, which is an innovator in low-cost medical devices. So each one of us, the three partners, bring in an expertise in a different stage of the process. But working together throughout the entire process, we make sure that everything we're working on has a high potential to actually make it all the way through. I'll give you one quick example. Cervical cancer is a leading cause of death among women still in developing countries like India. And one of the best ways to treat it is when you see the patient on examination has lesions on the cervix that you treat with cryoablation. Simple, fast, easy. What they use now is these big tanks of CO2. The best tool now is this cryoablation tool. One big tank can maybe treat 5 patients. It's difficult to carry around. It's difficult to have a camp where women can come in and get treated. Our students have come up with a device that, with that single tank, can treat 100 patients. With a portable tank, with a 20x reduction in cost per use, and a reduction in the complexity and maintenance. The innovation is simply stunning, the device that these students have come up with. And it's received tremendous amount of support from USAID and others. Here's another technology that we're developing. It's a low cost, on the right here, diagnostic for preeclampsia, another major killer of women in developing countries at time of birth. And it's easily detected by protein in the urine or high blood pressure, and easily treated if detected. But women don't get treated, and they don't get because it's not detected. So the students were charged to come up with an extremely low-cost diagnostic test. And the solution they came up with is to put the reagents for the test in a marker. So a field worker like a Asha in India can take the pen and draw on a piece of paper, make a mark, and then give it to the woman. She can urinate on the card directly. She doesn't need a container for the urine. And then the color change has been shifted. Instead of a color scale like your swimming pool thing that tells you how much chlorine you have, this thing gives you a clear dichotomous color change at the break-off point that's critical for that diagnosis. So anybody can read the test. So, and then you take the test from $1 or $2 per test to less than a penny per test, because every pen contains hundreds of tests in it. And the body of the pen is the color of the reagent, and the cap is the color of the positive test. So that's the students that received $250,000 in follow-on funding for development. In fact, my director of the graduate program right now is on his way to Nepal to field test the device. Here's another one that uses eHealth. It basically is an electronic partogram, which is a management tool, a decision support tool for labor and delivery. And the students have made a very low-cost version of this that uses SMS technology to relay the information to a central hospital. I won't go through all the slides. These are lists of projects, a diverse range of projects from every area. The only criteria, as I said, is clinical impact, commercial viability. And these are the ones from this year. And we also have a technology acceleration fund I talked about. And this is basically an invitation. There's a range of ways that you or your organization could work with us, and companies could work with us, and we welcome companies big and small. We have a lot of partners, and we'd like more partners in our network, and we welcome that. So thank you very much for your attention, and for your wonderful organization of Clear.
I know we are running a little bit late. Probably we can take 10 minutes of Q&A here, if that's okay with Dan. That works.
Yeah, that's fine.
So if, please feel free. And again, I want, yes, please go ahead.
It's a question for Doug.
Hold on. Here you go. Okay. Go ahead. Go ahead.
Hello?
Go ahead.
This question is for Doug. I'm just wondering, from a pricing strategy, when you have a product like yours, where it's hard, my sound of that, where it's hard to quantify the benefits. I'm not asking for exact pricing, but how do you justify pricing?
Good question. We actually started out by looking at comparable types of products that are being sold to benefits departments. And we actually use that as an anchor for how we would price the product. We were able to trial it with certain customers and see if they're willing to pay it. And I think we actually essentially market tested the pricing and are pricing now on what we believe people are willing to pay based on experience. So we do have a range, and we're doing some creative things for different types of customers. But I would assume we'll be flexible and continue to experiment with pricing for at least the next year, if not longer, while we figure out the best way to add value and to extract value from the customers.
This question is again for Doug. So interesting approach. So any reason why you limited it to the corporate customers and not open it to the consumers?
We actually have the ability for all users to invite a friend. We actually have permission for most of our customers to allow them to have the employees invite a friend, which is very different, once again, than the eligibility file type concept where it's only open to people that are authorized users. We make the pitch to companies that if what it takes to get Yusuf involved in a challenge and in more challenges is to invite his own friends into it or his family, that's okay. So we are seeding the consumer market by letting people bring in other people that are not involved in the company. Time will tell whether we decide to broaden that use among consumers. We decided right now that getting consumers to pay for an application like this, when there's other things out there that you can track on Lance Armstrong's site and Livestrong, whatnot. There's places to do challenges that don't charge anything. So we decided rather than fight that battle right now, we'd go where the money is. That's corporations.
Hi, this question's for Yusuf. With so many partners engaged here, who owns the IP and how does the revenue get split among the partners?
So the IP is owned by the university. Partners participate for a variety of reasons. Some of them because they want to increase the value, the pipeline of innovation coming out of academia. They get a front row seat on what we're working on. They help us steer the program in terms of choosing projects. And if they see something of great interest, they have a first look at it, de facto. But a lot of them are doing it because they're alumni of the university or the program.
Thank you.
Now, some partners actually sponsor projects into the process. So we have big companies have come to us with design challenges, said, we need you to re-engineer the epidural needle placement, or we need you to come up with a diagnostic for G6PD deficiency so we can use our malaria drug, or maybe someone like KP can come to us and say, we have this design challenge. And then they pay a fee and they sponsor a team and they get a right of first negotiation on the IP that's developed.
Okay. Thank you.
Yusuf, just on that question, what are the other mechanisms for a commercial entity to license your IP?
So there's the traditional tech transfer method where we develop something and then we show it to people and maybe there's a match. From my experience, that rarely happens. We instead prefer to have people come to us with a challenge, a problem they need to solve, and we solve it. They not only provide money. In the case of, for example, BD and GSK, we said, we don't want just your money. We want you to assign a person from your organization to be the mentor for this team throughout the year, and that way they're guiding it, they get the benefit of that, and then at the end of the process, if something cool has happened, they can license it out. So those are really the two main things. We try to shy away from the traditional tech transfer model.
Okay. And and if an entrepreneur wants to reach out to KP, what would be the best way to do so? Who would be the right person there to contact? And secondly, besides the projects that you do, is there funding available for outside projects as well through KP?
Yeah, the process is, if you're an entrepreneur and you're wondering if your invention is going to be accepted by the enterprise, we're very willing to meet with you as long as it's different. So usually what we do is we do maybe a half-hour phone interview. We just came out yesterday with a new tool where you actually can sign into our site and fill in the information, because we see a lot of companies. So the next step is, as you go through the process, if you find an internal stakeholder at KP who is interested in your solution, as I mentioned, we do have internal funding for essentially an angel round type funding for a fast project. And there are other pots of money that are even larger. We don't usually take external money to do that, although we may do that in the future, we're talking with academic institutions who are also interested in working with us to develop real solutions to real problems.
And what's the timeline to procure the funding through your organization?
It's actually a rolling monthly review,
Okay.
and so it's a multi-million-dollar fund, but it's sort of partitioned through the year, and the criteria, the primary criteria is actually innovativeness, disruptiveness. We've had things, a lot of Me Too things, and
So if I put in a proposal to the next month, I can get funding?
you
That's
can apply for funding, right? But regardless of funded or not, we love to give feedback because we love to see people develop real solutions, and we also like to see things early, so it's a win-win.
Okay.
I just want to say that actually we got the money from the Kaiser Permanente, the last company I was involved with.
Okay.
But I think it's different from this innovation
different,
fund,
right.
yeah, the venture capital fund.
Right, we have a venture capital fund as well,
Yeah.
which is.
I think I have a question for Johns Hopkins
Sure,
University. Actually, Bill Brody was on our board of the companies I was involved with. I was just wondering about how many of their licensees are from the Bay Area or they're from local? Do you have any criteria for that, or licensing the technologies?
No, really, our only criteria is who is most likely to have the wherewithal to take it forward and have an impact on healthcare. That's the main criteria. Where they're located is not that important.
How many of them are licensed thus far?
There's a lot of technologies out of the university that have been licensed. Our program has only been in place for 2.5 years, so none of the spin-out technologies has been licensed outside of Baltimore. The one that's being in commercial use now, well, actually, one of them has gone to a drug company, Auritus, and one of them is the Seguro surgical lap pack device, which is in a startup company in Baltimore. And the other 4 or 5 that I had on the slide are in startup mode, being incubated in Baltimore in an incubator.
The same thing goes for the investment side of it, like if you want to put money into the program.
So absolutely, we would welcome investors, and that's one reason why I'm here. So I'm very excited about the fact that you've created Thai Angels, and I think if I would have come here last year or the year before, we wouldn't be there. But I think now, after 2.5 years, we are primed. We have a pipeline that's more mature now, and we have companies that have had other funding. They've leveraged existing funding, state funding and grants, etc. And now they're ready, I think, to attract professional investment.
Hi, this question is for Chow. How much of your IT infrastructure is in cloud today? And do you see opportunities for entrepreneurs and businesses working in the cloud to look to KP for helping with the cloud migration?
Mm-hmm.
Thank you.
Yeah, I think we're looking at the cloud computing model right now. It's very difficult for KP because it's a healthcare organization to send data outside the firewall, and so for the near term, we're not thinking about doing that at all. But we are looking at doing non-PHI, non-personal health information type data, sending that out. So it's a very early stage right now. I would say it's probably going to happen in the future, but it's going to have a lot more stuff happen before that happens, including security and HIPAA compliance, all these kind of issues. So I would say it's still very, very early, but we are looking at it.
I had a question for Chow. In general, everybody is impacted by the rising cost of healthcare. In your opinion, who's hurting the most? Is it CMS or the employers who are paying premiums for the employees, or the beneficiaries who have the out-of-pocket expenses?
I think the people that are hurting the most is you and I, actually, because we're all paying what is it, up to $8,000 or $9,000 a year now for every man, woman, and child in the United States. We're paying for the care, and somebody's going to pay for it. Ultimately, we pay for it. I think that's an unacceptable level of investment in an industry that really should be a lot lower and should get better results. And that's basically what's happening. So It's interesting. It's changed a lot over the years. It's a lot of change from the right to pursue opportunity to the right to have health care, and without thinking about who's paying for it. And I think ultimately, we're going to get to a point where nobody can pay for it, and so then you're going to have to do something different. And so, we see things like in the paper today, people talking about, is it acceptable to prolong your life forever? We had a very low quality of life. Those kind of questions are coming up more now than ever before, just because people can't afford it. And the other issue is, where should the government invest the money? In very expensive procedures or in preventive care? So there's a lot of deep changes that have to happen before we really get major changes in who's hurting and who's not. Yeah.
One last question here, because in the interest of time.
John Hopkins, I was truly intrigued with all the things that you're doing. Do you have a presentation at John Hopkins, if I get on the internet, to go a little, read all of this? You're going so quick. I was not able to catch some of the most interesting things that I wanted to take a look at. But it is fascinating. Where can I learn more about what you were talking about up here?
So I'll invite all of you on May 7th is our flagship event at Baltimore. And you can spend the day with us then. We'll provide food. And in the entertainment will be this stuff. All the student projects will be presented. All the top ones, the best ones will be presented. There'll be posters. So if you could show up, that would be awesome. The registration is on our website. The address of the website is cbid.bme.jhu.edu. It's pretty straightforward. Would you like me to write it down? I should have put it on the slide.
We can get that if you give your contact information. I'm sure we'll get that.
I'll give you my card. It has it on there.
All right. Well, again, a big round of applause for our speakers today. Thank you everybody for coming for this session. Thank you.